Hello, my name is Justin Peacock. I am a nuclear medicine fellow at Brooke Army Medical Center. It is a pleasure to present to you today on the use of nuclear medicine in brain neoplasm imaging. In presenting nuclear medicine topics, I like to start off with presenting the radiotracers that I will be using and discussing. The radiotracers commonly used in brain tumor imaging include 99M technetium HDP/MDP, 18F FDG, 111 indium pentotriotide or octreoscan, or 68 gallium dotatate, 99M technetium sestimib, and 201 thallium. The pathologies that I will be discussing today include benign and malignant tumors, including metastatic brain neoplasms. So let's begin with this discussion of the radiotracers and their properties. Some of these radiotracers are more commonly used than others when looking specifically at brain neoplasms, but it is also important to be aware of some radiotracers that may demonstrate brain tumors when whole body imaging is employed for a different reason. So let's start off with 99M technetium HDP/MDP. These are two radiotracers commonly used in bone scintigraphy. Both of them have a 6-hour half-life owing to the 99M technetium radionuclide that they contain, and both are incorporated into newly formed bone through direct chemoabsorption. The radiotracers can be imaged using either planar or SPECT/CT imaging techniques. While commonly used for bone pathologies, the radiotracers can also localize to other tumors, including meningioma. The images on the right are from a normal anterior and posterior whole body bone scan. But these bone scans should always be carefully scrutinized for both osseous and non-osseous abnormalities. The next radiotracer is 18F FDG, or 18-fluorine FDG. It has a half-life of 110 minutes. As a glucose analog, it localizes predominantly in the brain in gray matter, where there is elevated energy production, as can be seen on this figure on the right. The highest localization in the brain is the basal ganglia. As a positron emitter, the radiotracer is imaged using PET-CT. In neurologic purposes, 18F FDG is used in dementia imaging, brain tumors, both benign and malignant tumors, infection and inflammation, and in epilepsy. In particular, in epilepsy, it is used in interictal epilepsy most commonly. The next radiotracer is 99M technetium sestimib. Again, this radiotracer utilizes technetium, and so the half-life is 6 hours. It is a lipophilic molecule, meaning that it likes to enter areas that are nonpolar or lipid layers. So it is rapidly absorbed through first pass extraction across the blood-brain barrier. This then leads to prominent uptake in lipid layers, particularly intercalating in the mitochondrial membranes. This results ultimately in its prominent myocardial uptake, as can be seen on the images on the right, and on myocardial perfusion studies. Planar inspect imaging can be performed on these using this radiotracer. And the most common uses are obviously going to be your myocardial perfusion imaging and parathyroid imaging, but we can also use it in brain imaging, including post-treatment brain imaging. This figure on the right demonstrates an example of sestamibi used in a different setting. Namely, it was used to look for metastatic tall cell variant papillary thyroid carcinoma, which you can see in many foci, including the cervical soft tissues in this patient, the mediastinum, and the liver. The next radiotracer is 111 indium pentriacetate, or octreoscan. This is a radionuclide linked to a somatostatin receptor binding analog, namely pentatriotide. The indium-111 radionuclide has a half-life of 67 hours. Again, the biodistribution is going to be wherever we see somatostatin receptors. Planar and SPECT-CT imaging can be performed with this radiotracer, and its uses are predominantly looking for neuroendocrine tumors. Although interestingly, as it's been used, it can also localize to other tumors that are non-neuroendocrine tumors, such as meningiomas. The figure on the right is from a negative octreoscan for carcinoid tumor. Interestingly, this scan missed small carcinoid metastases that were picked up later on a much more sensitive 68 gallium dotatate PET scan. This brings us to the 68 gallium dotatate radiotracer. This is a newer radiotracer that similarly links a somatostatin receptor binding analog, dotatate, to the radionuclide 68 gallium. I love the half-life of this radionuclide of the 68 gallium because it's very easy to remember. It is 68 minutes. It is much more sensitive than octreoscan for detecting neuroendocrine tumors and is rapidly replacing octreoscan for this purpose. It is imaged as a 68 gallium gives off positrons with PET-CT. And as I mentioned, it's commonly used for neuroendocrine tumor imaging, although like octreoscan, it can localize to other tumors such as meningiomas. The figure on the right is from a dotatate scan MIP image, and it was used to image an organ of Zuckerkandl paraganglioma at the aortic bifurcation. And as you can see, it gives beautiful sensitivity and really nice resolution, with very few structures taking up the radiotracer other than the tumor itself. The last radiotracer is 201 thallium. This has a half-life of 73 hours. Thallium, as a radionuclide, is very similar to potassium. So the way that it is taken up is through active transport, through the sodium-potassium ATPase. So it's going to localize predominantly in viable tissues, and particularly in the muscle. Planar and SPECT imaging can be performed with this radiotracer. And its common uses are in cardiac viability imaging, but it can also be used in brain tumor and post-treatment imaging. The example in the figure on the right is that of thallium uptake in an AIDS patient with biopsy-proven right cerebellar lymphoma. You can see the ring-enhancing lesion in the right cerebellum, which avidly took up the radiotracer thallium, as can be seen in part B on the right. So now we're going to turn our attention to the application of these radiotracers in benign tumor imaging. And I'm also going to insert at the end a small aspect of nuclear medicine therapy in this arena, which I think is very exciting. So the main benign tumor that I'm going to be talking about to you today is meningioma. A couple facts about meningioma. It is the second most common primary brain tumor. It is often incidentally found on various imaging modalities, including nuclear medicine imaging. Most meningiomas are grade 1, which is classified as benign, or grade 2, classified as atypical. This represents about 97 to 99%, with the remaining 1 to 3% being grade 3 or anaplastic tumors. In terms of nuclear medicine, it can be seen on a wide variety of radiotracers, as I mentioned, including the 99M technetium HDP or MDP, 18F FDG, 111 indium pentriotide or octreoscan or gallium-68 dotatate, and 201 thallium, and 99M technetium sestamibi. Interestingly, given the uptake of dotatate within meningiomas, treatment now not only involves observation, surgery, radiotherapy, but more recently also nuclear medicine therapy, and I'll get to that towards the end of this section. So now let's turn to some examples. So this is a bone scan in a young female patient who had previously had resection of a large anaplastic meningioma centered in the skull, particularly along the falx. And what you can see on this bone scan is that if we window things appropriately, you can often pick up meningiomas on bone scan. And hopefully what you can see overlying the frontal bone is some uptake within the recurrent meningioma that this patient suffered from in the skull and brain. This patient also had a metastasis to the spine, and hardware was placed in the spine, which you can see on this bone scan. This bone scan was performed because the patient also demonstrated a new lesion in the left iliac wing, and this was resected and found to also be an area of rare meningioma metastasis outside the neuroaxis. So what you can see is that meningiomas and their metastases can significantly take up MDP. Here are examples from her CT with the recurrent metastatic meningioma along the falx and extending through the parietal skull. The CT of the pelvis demonstrates an aggressive, destructive soft tissue lesion with peripheral calcifications, which again was resected and found to be metastatic disease. This is an example from Burrell et al. That demonstrates a recurrent atypical meningioma that was found on a octreoscan. Whole body imaging demonstrates a linear midline mass overlying the skull. When we add the power of SPECT-CT to this, what we find is that this recurrent meningioma mass overlies the posterior falx with surrounding parenchymal edema. Here are examples of gallium-68 dotatate used to detect recurrent and metastatic meningioma. So this patient had had a left optic nerve sheath meningioma that had been resected 8 years prior, And then on MRI and gallium-68 dotatate PET-CT, what you can see is there is recurrence of the meningioma to the left optic nerve sheath. And additionally, a metastatic focus is noted in the left cerebellopontine angle. Sometimes these small metastatic lesions may be missed on routine imaging, but you can see on the dotatate fused images that dotatate highlights the lesions very nicely. Now I'm going to turn my attention briefly to what I think is a really amazing topic in nuclear medicine therapy, or theranostics, which is the combination of diagnostic and therapeutic radiotracers, which is the beauty of nuclear medicine practice today. Given that dotatate is often positive in meningiomas, we can swap out the radionuclide from a positron-emitting gallium-68 radionuclide for a beta-emitting Y90 or lutetium-177 radionuclide. And then we can directly treat these sites of disease with low side effect profiles. When I'm talking to patients, I often liken the tumor to a lock. We can have keys with different heads that all fit the same lock. Similarly, we can use the parent dotatate molecule and attach different radionuclides to diagnose or treat disease. In this figure from Marincek et al., the authors looked at the overall survival of meningiomas based on the degree of dotatalk, and dotatalk is an analog of dotatate, uptake when they were treated with 177 lutetium dotatalk. As expected, those with high uptake fared significantly better than those with intermediate or low uptake. This and other articles demonstrate the power of nuclear medicine theranostics in personalized treatment of meningioma among other tumors. So now let's turn our attention to malignant tumors, including the most prevalent brain tumor, tumors that metastasize to the brain. There's going to be some key points that I want to summarize here. First, 18F-FDG is limited in imaging brain tumors due to intense uptake in normal brain tissue. High-grade tumors such as lymphoma and certain metastases demonstrate intense FDG uptake that is above and beyond the parenchymal background. Intermediate and low-grade tumors may not be able to be differentiable or differentiate on 18F-FDG due to this background activity. 201 thallium and 99M technetium sestamibi can demonstrate increased uptake in malignancy. And many radiotracers can differentiate tumor recurrence compared with radionecrosis, which is often difficult with MRI alone. Some of these radiotracers that have been used in the literature include 18F-FDG, 201 thallium, 99M technetium sestamibi. So let's dive into some examples of using nuclear medicine radiotracers in initial diagnosis. Again, while less common, these tumors may be discovered incidentally on nuclear medicine studies. So it's important to carefully scan all of your nuclear medicine studies to see if there are brain tumors. Particularly when we're looking at FDG PET scans for a distant primary tumor, it is important to scan the brain to see if there are metastases. So in this first example, what I'm presenting to you is an example from Sishan et al. Of a glioblastoma that was visualized using 99M technetium sestamibi. And what they did was they fused the SPECT images with MRI and with CT, so you get SPECT MR or SPECT CT, And you can see that it nicely highlights the glioblastoma as seen on the comparison MRI and CT scans. This is another example, in this case using 18F FDG, and what you can see is that in this case with high-grade diffuse large B-cell lymphoma, it is much more intense in terms of its FDG uptake in comparison with the background brain uptake. So for these high-grade lymphomas, you can often see and utilize FDG scans to image these tumors. And you can see this large tumor in the left frontal lobe extending to the lateral ventricle with significant surrounding edema on MRI, and it is intensely FDG avid as seen on the whole body MIP images in A, the PET slice image in C, and the fused image in D. Lower grade lymphomas will be difficult to distinguish from FDG background uptake on these scans. Many metastatic tumors, which represent the highest percentage of brain tumors, demonstrate intense FDG uptake above background. An example of such a metastatic tumor here is a pulmonary epithelial angiosarcoma, which demonstrates intense primary tumor uptake in the lung, which you can see in C, and then on the fused images below, and then also similar intense FDG uptake in the brain metastasis with significant surrounding parenchymal edema, as seen in the B column and on the fused image at the bottom. So this is an example of a solitary brain metastasis with intense FDG uptake above parenchymal background uptake, which could be imaged with FDG PET-CT. This is an example of a brain metastasis that does not demonstrate significant FDG uptake on PET-CT. This is an example of a lung cancer, and although the lung cancer itself in the right lung apex is FDG avid and can be seen very clearly both on CT as well as on the PET-CT fusion, the brain metastasis in the left parietal lobe is very clearly hypometabolic on the PET-CT, as can be seen in the coronal images of the fused PET-CT. On the right-hand side, you can see that the brain MRI, the FLAIR MRI image, demonstrates this brain metastasis very well with mild surrounding edema. So it's important to realize that not all brain metastases or brain tumors are going to be FDG avid significantly above background, and so FDG PET is maybe not the best use of them. But it's also important to realize that some of them are significantly hypometabolic, like this lesion, and may present an area with decreased metabolism in the brain. So it's important when you're analyzing FDG PET scans to look for both hypermetabolic or intense lesions as well as hypometabolic lesions, as in this case. It is also important to always use and cross-reference any available cross-sectional imaging. A common place where nuclear medicine radiotracers have been used and are used is in the realm of determining whether a brain neoplasm has recurred after treatment, or whether what is seen on other imaging modalities represents radionecrosis or post-treatment effects. This is often difficult to distinguish on MRI, including contrast-enhanced MRI. The unique functional features of radiotracers can be used to help distinguish between these two entities. Here's an example of recurrent glioma on MRI on the right and on FDG PET-CT, where the PET images are displayed in axial, coronal, and sagittal views. As you can see on the FLAIR images on the right, it is often difficult to tell what is tumor versus what is just post-treatment effects and necrosis. In the midst of the FLAIR changes on MRI, you can see that the FDG is able to detect a small hypermetabolic lesion among these changes, and that this hypermetabolic lesion is recurrent glioma. This is another example of using FDG PET-CT to determine radiation necrosis versus recurrence status post-radiation therapy. In this case, after therapy, there's a large cystic area with residual T2/FLAIR changes in the parenchyma surrounding the cyst. Now, it might be difficult off of just the MRI to say whether this all represents radiation necrosis or whether some of it may represent recurrent tumor. So in this case, when FDG is used, you can see that there is no significant FDG uptake within the cyst or within the parenchyma surrounding the cyst, suggesting that this represents an area of radiation necrosis without evidence of disease recurrence. Here's an example from a paper by Lai et al. Where they were comparing contrast-enhanced MRI, which is the leftmost column, with thallium SPECT, which is the next column, and FDG PET-CT, which is the next column, and then lastly with arterial spin labeling MRI, which is the rightmost column. And they looked at it in multiple different metastases to the brain. Row A represents renal cell carcinoma metastasis, or concern for metastasis, and it was actually biopsied and found to be necrosis. And so what you can see is that it was identified on contrast-enhanced MRI and SPECT, thallium, but it was negative on PET and arterial spin labeling. And so the biopsy was found to be necrosis, and PET and arterial spin labeling corresponded with that diagnosis. Row B is an example of a breast cancer metastasis that was treated, and this was biopsied and found to be tumor recurrence. And so the contrast-enhanced MRI was positive for that. The thallium SPECT was actually negative for that. The PET, FDG PET, was positive for recurrence, and the arterial spin labeling was positive for recurrence. And then row C is a melanoma met that was treated, and this was biopsied and found to be recurrence. And it was positive on contrast-enhanced MRI, thallium SPECT, and FDG PET, but not on arterial spin labeling MRI. So you can see that overall FDG PET responded well in terms of being able to detect radiation necrosis or tumor recurrence. Overall, the authors concluded that FDG and arterial spin labeling were equally sensitive, and that arterial spin labeling was possibly more specific than FDG, but both outperformed thallium and contrast-enhanced MRI in determining between residual or recurrent tumor and radiation necrosis. I'm going to turn attention for the last bit of time onto some new amino acid analog radiotracers that I think have significant promise in this area of brain tumor imaging. They've been used commonly in Europe and should be coming shortly to the United States. and will have significant impact on tumor imaging and tumor recurrence imaging. To be brief, most of these amino acid analog radiotracers are all transported to tumors through a similar mechanism, and that is through amino acid transporters. Brain tumors tend to upregulate these amino acid transporters, so amino acid analogs are readily taken up into tumors. The benefit with these amino acid analog radiotracers is that they have very low background brain parenchyma uptake. And so with that low background compared with FDG, they're very sensitive and specific for identifying tumor and tumor recurrence. So I'm just going to talk about two of these. The first is 18F-F-DOPA, and this is an 18 fluorine coupled with DOPA molecule, and it's a radiotracer that localizes to the striatum, to the caudate and the putamen. It is actually currently FDA approved for Parkinsonism and has a similar uptake to that of I-123 ioflupane, which is used in DAT scan imaging. Off-label, it can also be used to look at brain tumors and look for tumor recurrence. This figure demonstrates an oligoastrocytoma, a grade 2 tumor, which shows intense FDG uptake, even though it is located close to the putamen on the left. And so you can see that on the fused image down in the lower left-hand corner. You can see that on CT, this is difficult to appreciate. On FLAIR MRI, it is more readily apparent, although that could also represent an area of edema. And on contrast-enhanced MRI, T1-weighted MRI, you can see that there's that area of edema. It's difficult to appreciate the tumor within it. It is readily apparent on the F-DOPA image. And you can see how low the background, other than the striatum, is for F-DOPA, and so this readily identifies lesions on PET-CT imaging. This is another example of a different PET radiotracer that is used in Europe. It is 18F labeled fluoroethyl L-tyrosine, or FET, and it is also taken up by amino acid transporters in brain tumors. As can be seen on these images, they broke these tumors down by grade, looking at grade 1 gliomas, grade 2 gliomas, grade 3 gliomas, and grade 4 gliomas, and all demonstrated significant FET uptake with relatively low background brain parenchyma uptake. Comparison MRI images are shown to the left of each tumor. So in summary, there are many different radiotracers, including new PET radiotracers that are coming out that can be used for detection of benign, malignant, and metastatic brain tumors, as well as tumor recurrence following treatment. While it is limited for brain tumors, many tumors may exhibit significantly increased or decreased FDG uptake relative to the brain parenchyma, so it is always important to carefully scrutinize FDG PET-CT to particularly assess for brain metastases from a distant primary tumor. Diagnostics in nuclear medicine is an exciting new field that may allow for targeted treatment regimens for brain tumors such as meningiomas, among others. And it's always important to be aware of novel radiotracers that may overcome the limitations of FDG imaging and brain tumor imaging, and these include new amino acid analog radiotracers. It's been a pleasure to talk to you today. If you have any questions about the presentation or the topic, please feel free to email me at justin.g.peacock@gmail.com. I'd be happy to answer your question. Thank you.